Endoscopic band ligation in diverticular bleeding, a stepwise approach for successful treatment. The authors have nothing to disclose. A 90-year-old Caucasian gentleman presented to the emergency department with an episode of painless hematochezia for several hours. His medical history was remarkable for severe diverticulosis in the sigmoid colon and diverticular bleeding previously treated with thermotherapy and clips. On physical examination, his vital signs were within normal limits. Digital rectal examination demonstrated gross bright red blood with no evidence of hemorrhoids. His laboratory findings included normal levels of hemoglobin and hematocrit, as well as a normal level of BT, BTT, INR, and platelets. The patient underwent a rapid bowel preparation. A standard 4 to 6 liter colon purge was intended. The patient was closely monitored, and after drinking 2 liters of polyethylene glycol, the rectal effluent was already clear. A diagnostic colonoscopy was performed the same afternoon using a high-definition white light adult colonoscope. During colonoscopy, the terminal ileum was intubated, showing no evidence of blood coming from the small bowel. Upon careful withdrawal of the colonoscope, fresh active bleeding was seen in the sigmoid colon at 40 centimeters from the anal verge. A tattoo using spot ink was immediately placed in the vicinity of the bleeding diverticulum, so we wouldn't lose its exact location. Treatment options were discussed and included epinephrine injection versus electrocoagulation versus clipping. However, it was noted that the bleeding was well inside the diverticulum, which would make either option more challenging. A more feasible option included a cap-assisted inversion of the diverticulum followed by a band ligation. Therefore, the colonoscope was exchanged for an adult gastroscope, and a second tattoo was placed immediately adjacent to the bleeding diverticulum in order to identify the exact spot for treatment. Subsequently, the gastroscope was removed and a variceal vending device was attached to it. Upon application of suction, a mucosal tear was created. However, the whole diverticulum was inverted, and the band was placed successfully, achieving complete hemostasis in the area. The patient was discharged home the following day with a stable level of hemoglobin and no evidence of lower gastrointestinal bleeding. To date, he has not had any further recurrences of hematochezia. Literature suggests that in some instances, endoscopic band ligation may be superior to hemoclip placement, especially for prevention of early rebleeding from diverticular-related hemorrhage. Ulceration bleeding and perforation are potential risks associated with EBL. However, the true incidence is likely to be lower in the left colon. Diverticular-related bleeding is oftentimes very challenging to diagnose and manage. Some key points in the management of our patient included administration of a rapid colon purge the same day that the patient was admitted, followed by a diagnostic colonoscopy. Furthermore, intubation of the terminal ileum and a careful withdrawal of the colonoscope are essential techniques, as the former would potentially exclude a small bowel bleeding source, and the latter ensures a high-quality examination. Third, when an area of bleeding is seen, care should be taken to immediately identify and isolate the diverticulum, as this type of bleeding frequently is intermittent. A tattoo is often helpful to locate the source of bleeding, should exchange of the scope or subsequent surgical therapy need to be performed. Last, different treatment options exist for the management of diverticular-related bleeding. When direct targeting of the vessel of interest is not possible, one should consider inverting the diverticulum with a clear suction cap, followed by bending of the inverted diverticulum.